So I have a question about zero carb ketogenic diets. Not many people do that, but I know that some people do that. And my question is, what happens to the intake of minerals and vitamins on such a diet? I know that in earlier times, people would be eating not so much meat, but maybe organs. And they might be getting a lot of more nutrients than just eating chicken breast or steak. And also the lack of plants, how does that affect your general health? Are you ever deficient in nutrients? Because I'm thinking you must be. But anyway, I guess those are my questions.
Is that question directed to anybody?
Anybody who has an answer?
So what are the nutrients on a zero carb diet?
What would a person be lacking in nutrients on a no carb diet, only fat and meat?
If it's properly formulated, nothing. So
so how does anybody learn how to properly prepare? Because we don't know necessarily. We just go kind of blind.
Well, the science that's been done has really not addressed a zero carb diet. The science that I've been involved in for the last 20 years would use a 20-gram vegetable sources of the carbs, and that has been studied over and over. So you're asking something that I don't think really has been well studied in the medical literature. You can make teleologic argument, you can argue history, you can argue carnivores and all that, and there's some validity to that. But I don't know that anyone's really studied a zero carb diet yet.
Okay, thank you.
Next question.
Okay, my name is Amanda. I'm a recovering diabetic, as it were. I started off at 9.5 and I'm down now to 5.5. I started LCHF the day after I was diagnosed. I've got a question for Berta, actually, which is, we've seen in other studies that ethically you have to stop having people be the control group when something's proved to work. You've now got a year's worth of data showing 400 people that are recovering, 100 people who are going nowhere and getting worse. At which point do you actually say to those guys, you have to come over to our side?
Well, we don't ever say you have to, but this study is continuing on for 2 years. We're about wrapping up that, and again, at the end of the study, as far as letting those people switch over to a low-carb diet, they all have the option to do that by enrolling in our clinic right there at IU where the study was taking place. And so that's definitely offered as an option for them. Whether or not they want to take us up on it is up to them. But
so they will already know the results of all this at that point.
Yes, because it was published before they completed their 2 years. So it's absolutely an option for them. Okay.
And while I'm here, I'd just like to make one quick sort of selling. Diabetes.co.uk. If anybody's interested in looking at 1,000 plus N=1 experiments over the last 10 years of how to make this work, they're all in there. Just go on that website, take a look. The website is diabetes.co.uk. If you go onto their testimonials page, you will find, going back ever since 2009, people doing this diet and succeeding.
Thank you.
Hi there, my name is Walt. I just want to say thank you for all your presentations. I've got a pretty general question, and it's about a common theme that I've seen, and it's pretty obvious, but all of these studies are done under really close medical supervision. And myself, I'm just a chemical engineering student. I only have my personal experience, research, and watching videos like what you guys put out. So I want to know if there's any place in all of this for people like me without having to go through 12 years of school, essentially, medical school. And also, to tag on to that, do you think people like us are at an advantage because we're not put under a microscope of the institution? And directed towards anyone.
Well, okay, so I'll take that to start at least. So I think there are plenty of resources available. I mean, the number one resource for someone who is interested in starting a low carbohydrate, high fat diet, I usually refer them to Finney and Volek's book, and that's a really great starting point. And for if you're otherwise healthy, I mean, there's no reason why you can't go out on your own. I do always, I mean, no matter, who you are, what age you are, your current health status, I recommend, especially as a past primary care physician, everyone should have a primary care physician. You should let them know what you're doing. But do you need close supervision if you have no other health concerns? Can you get enough information, again, from sources like Finney and Volek's book to go out and do this on your own? Yeah, I think you can. But again, I'll just put the plug in for primary care physicians. It's always important to have someone in case there's problems. Yay, primary care physicians.
Sorry, maybe I should specify in relation to helping other people, like spreading the word. Because I don't want to do any harm,
sorry,
you know what I mean? Because I'm not a medical professional.
Oh, well, spread the word. Yes, I mean, I think that, and I tell my patients this all the time when they come in, you are the catalyst, right? Looking and seeing you and seeing the success that you've had, and that's going to help the next person. So one of the things I encourage all of my patients is be a teacher. Be a teacher in your workspace, right? Be a teacher at home with your family. And, pretty soon that's how we're going to change things. So please, be that catalyst in your community. I think that's fantastic.
All right.
Yeah.
I just want to echo the idea that anyone can do this. There's no biologic reason for you to eat sugar, and starches get digested to sugar, so don't worry about it if you don't have medical problems. But if you want to learn how to do it, Heal Clinics will train you to become a partner. And so one of the missions that I'm on is to create a company that will train people to help other people to do it. And if someone's on medical medications, then they need to see someone in a clinic, but they don't have to. They can be taught at a difference by trained partners. So check out the booth.
Right on, will do. Thank you.
Okay, thanks.
Hi, my name is Nathan Weens. I'm a family medicine physician assistant in Spokane, Washington. I've been doing low carb myself for about a year now and have been very successful and have gotten real passionate about this. I'm working with my patients, but I really want to go a little bit deeper and eventually want to specialize in obesity medicine. I'm sitting for the interdisciplinary certification in obesity and weight management, actually in 2 weeks. But I was wondering, particularly Dr. Eastman, Dr. Hallberg, if you've got any other suggestions for somebody who is an aspiring obesity medicine provider.
Well, you didn't refer to the American Board of Obesity Medicine.
Actually, I contacted them, and because I'm a PA, I'm not able to sit for that board.
Yeah, so the Obesity Medicine Association is a group of doctors who use medication, lifestyle, very low calorie diets, 1,800 around the U.S. There are two conferences a year. I would have you go to those for a deep dive into being a practitioner in obesity
I'm a
medicine.
member.
Awesome.
Yeah.
I don't know of any program for mid-levels, we call, in the
Right,
doctor
yeah.
world yet.
Wonderful.
All right.
Okay,
Anyone else
thank
answering
you.
that? Or move on.
Hi, my name is Jeff Williamowski. I'm an MBA student at the University of Chicago. This question is probably mostly for Sarah, but others feel free to chime in. And I'll preface it by saying, you probably don't want to interfere with the current trial, but for future cohorts or future trials, have you considered any other intervention factors like magnesium deficiency and supplementation, high-intensity interval training, partial day fasting, or exogenous ketones?
I'd love to see every single one of those things be done. No question. I think that there's so much to be learned still. And so when we started the trial, it really comes down to, priorities. Not to say that all those things aren't important. Actually, I honestly think the next step in trials is looking at more minority patients. This was central Indiana. They were mostly Caucasian. So I think that we want to get better data there, look at it more. It hasn't been studied exclusively in seniors. So I agree, and I think our next best move here is to continue to talk about this, continue to work for guideline reform also, to try to get the NIH interested in funding the right studies.
Thank you.
Thank you.
So, David, you mentioned that clotting factors were most important for heart attacks. This seems plausible because blood clots are probably involved in heart attacks. But there is also a less bad outcome of coronary artery disease, which is exertional chest pain, which typically happens when some lesions grow too big in arteries and partially block the blood supply. So for that, what factors do you consider most important?
I had a little. Is this my?
No. Maybe if we just see if I can switch that off.
I had a little difficulty understanding or hearing your question. Was this late stage atheroma? Is that what you're referring to?
No. Like some people just have exertional chest pain.
Stable angina, perhaps.
Stable angina. So they don't have heart attacks, but some lesions in their heart in their coronary arteries grow big enough and partially block the blood supply, and then they feel chest pain during exercise. So,
well, as a scientist, I know my limitations, and so and I'm not a clinician. My primary interest has been to understand what actually causes coronary heart disease, and I think from the very beginning, I focus on the angry platelets, and people tend to think that's only at the late stage. But from every aspect of cardiovascular disease involves activation of platelets and insufficient clot fibrinolysis. So I don't think I should go beyond specifically what I've researched. So stable angina is really not my area.
Do any clinicians want to answer? Okay. We'll move on. Next question, thank you.
Hi, I'm Nick, and I've got a comment and a question for David. The first comment is, I think even the 1% relative difference may be being quite generous, because we're talking about the stacked deck here of the best data that the pharmaceutical company could cook. And when we look at people like Rory Collins at the CTT and other corrupt individuals, it's clear that there's been a huge amount of data hiding, which is even frankly admitted to, and cherry picking and peculiar exclusion criteria and all sorts of things. So I think we need to remember that the 1% isn't this kind of platonic truth. That's the best amount of distilled corrupt data that was possible. So it may well be in a decade or two's time that we'll actually be thinking, oh my God, we know the truth of statins. There was actually an increased overall mortality. And some of the non-industry studies are beginning to point that way. So I've got a bet with somebody about what we're going to be saying about statins in 10 years. My question is, bearing in mind that the LDL hypothesis has been fully falsified in a Popperian sense, because if you think about FH and if you think about the ApoB status of the ketarvins and so on, that's it. There should be no more discussion. The fact that that hasn't led to a complete turnover of the way people are practicing and thinking, it's a cultural problem and it's a commercial problem. We could talk at these conferences for decades and people wouldn't believe that. So what do we do about that problem? Who do we need to convince? Or who do we need to sue?
Oh my. Yeah, that's a $64 million question. I mean, how do we bring about change? And I come across physicians all the time who are afraid to not put to tell their patients they don't need to be on statins. They're concerned about the legal aspects. Ultimately, you've got the powerhouses, the American Heart Association, which to a great extent dictates policy. So there's a lot of fear out there. But I do believe the word is getting around. A lot more people are realizing the ineffectiveness and the danger of statins. And frankly, there's also evidence I didn't have time to go into of cancer as a result of long-term use of statins. So I think the information is getting out there, but just like the dietary guidelines, I mean, it's tough to change convention, change the people in power.
You're correct. My 92-year-old grandmother was told to go on statins because she had high cholesterol. Fortunately, I was able to persuade her with studies that old people really shouldn't be doing that. She's 97 now and didn't listen to her doctor, thank heavens. So that's all we have to do.
I want to compliment you. Very well said. You went beyond where I would have considered appropriate for a presentation, but I agree with everything you said.
I have to say my 95-year-old mother has been on statins since she had an infarct a few years ago, and she has intractable leg pain. And I suggested to her that maybe the statins were the cause of her leg pain and she should maybe go off her statins. So she put that to her cardiologist, who said, don't be ridiculous. Thousands of people would be dead if it wasn't for statins. There's no way you're going off statins. And she probably wisely chose her cardiologist rather than her son. But I think in this case, she might have been wrong.
Thank you.
I have two questions. My name's Christine. I'm a second-year internal medicine resident. My first question is for Dr. Brukner. In regards to muscle fibers, slow versus fast twitch, is there a metabolic difference, preferential difference in carbohydrates versus fats? And does that play a role in this intensity dilemma that low-carb dieters see? And my second question is for Dr. Diamond. It's more of like a devil's advocate in regards to the 44% association of statins with diabetes. Most people are prescribed statins because of dyslipidemia, which is kind of linked to metabolic syndrome, which is linked with insulin resistance, but pretty much saying that these patients are on their way to getting diabetes anyways, or already have it. So I'm wondering, have they just not gone for a Kraft curve?
I'm sorry, what was that? They just haven't gone for what?
To get like a Kraft curve tested or postprandial insulin or, a better marker for diabetes.
Was the first question you were directing to? Yeah, go ahead.
You're just stalling. I wanted to stall too. Look, I think that's an interesting concept. So basically, we're talking about fast twitch and slow twitch fibers. Is that the reason why the slow twitch prefer fat and then the fast twitch prefer carbohydrate, which is a very sort of simple, attractive concept. But obviously, no one has purely slow twitch or purely fast twitch. We're all a mixture of those. So it's not quite as simple as that. I don't think anyone's really looked at that comprehensively. But it's an attractive concept that could explain that difference between the need for carbohydrate for high intensity activity and the need for and the appropriateness for fat for lower intensity. But I don't think it's quite as simple as just the metabolism of the different fast twitch and slow twitch fibers. But I certainly don't profess to be an expert on muscle metabolism.
So I've forgotten your question by now. But I think it had to do with dyslipidemia actually needs to be treated by a reduction of lipids, and that people are heading in the direction of diabetes, so therefore that's a rationale for statin treatment?
Well, no, just there was the association with statins and the development of diabetes. And I guess I'm trying to argue, is it possible that these people who were put on statins were undiagnosed diabetics?
Oh, well, yeah, that was actually an RCT in which actually you have people that are equivalent at the beginning of the study of a control group. Okay. But understand, it's not just one study. I picked that study to show that it was an RCT, but the Jupiter study was one of the first, and this is self-reported to physicians. People in Jupiter were reporting they were developing diabetes at a much higher rate in the experimental group compared to controls. And you have other trials as well. And their mechanism is known. You're actually interfering with mitochondrial function in the pancreas. So this is clearly, without a doubt, you're at risk for developing diabetes, and it'll occur eventually with someone with statins.
So are there any trials that show a worsening of diabetes after patients are placed on statins, which is common practice for diabetics?
I'm not, sometimes you don't find what you're not looking for. And I doubt that's actually something that the drug companies have looked for. But I'm not aware of a trial that's actually looked at that.
Okay, thank you.
So if I could just insert in your medical student mind, there are other approaches than medications. In medical school or residency, we often are only taught about medications.
That's why I'm here.
Thank you. That's why she's here.
Thank you.
Okay, my name is Tony Martinez. I'm an attorney, and I'm also the new head of the PHC USA. We'll talk about that tomorrow. I know some people are traveling, but the talk that I will give will be available. You'll be able to see it. I wanted to speak to Dr. Diamond, who I congratulate on an outstanding presentation that highlights what I take as both as an attorney and as a patient of a case of fraud that's being perpetrated on the public, because nobody tells the patients that, hey, we're going to put you on a raffle ticket or a lottery ticket odds to see if you're going to get the benefits. And with all of the side effects and all of everything and the costs, it's really bad. And the problem that you mentioned, you say, well, what can we do? The problem is a legal problem. The problem is in the law. The problem, first of all, there needs to be accountability and transparency about the data where these decisions are being made. We are not getting full transparency on that. Then there needs to be really honest, not deceptive marketing that's been taking place. We're going to work to change that. The Food and Drug Act, everybody needs to understand that everybody is operating, we're all operating under the Federal Food, Drug, and Cosmetic Act. That is what approves everything that is a drug or anything that is marketed for the prevention and treatment of a disease. And in that context, we have huge industry, the pharmaceutical industry, which is always looking for now huge blockbuster billion-dollar drugs, and that's the model they've been operating on because it takes so much money and so much investment to get anything approved. But anyway, that's for another topic. But Dr. Diamond, I want to invite you and encourage you to keep speaking up and to be available, because there's lots of avenues to attack this at the state level and even at the federal level, because this has to stop. This is not sustainable. So.
Well, again, I thank you for the comments. You think about how challenging it is to change the dietary guidelines, and I have such great admiration for the Nutrition Coalition. As far as statins are concerned, you're up against $1 trillion industry, and you've got the American Heart Association on their side. So that's going to be so much tougher than changing the dietary guidelines. So we're up for a great challenge. We've got, basically, it's two fronts in this war. It has to do with serum cholesterol, what you do about it, and it has to do with your diet.
Well, it's a worthy undertaking because, again, it's about health, and that's what we're focused about. So, thank you.
Thank you. Thanks.
Hi. I've got a question about performance within the low-carb diet. So, I'm training for some ultra marathons this year, and I'm on the low-carb diet. I've played around with it myself with grams of carbs, and I would, anecdotally agree with all the principles you talked about of, train low, perform high. I'm on probably about 75 grams a day on average of carbs. And the runner you referenced, Zach Bitter, he's one of the coaches in a coaching group that I use, and he recommends in races to take in about 200 grams or 200 calories an hour during these races. Because even though you're mostly fat burning, you're still burning some carbohydrates, and those you have to replace. So I didn't know if you had experience with kind of the rate of replenishing those carbs during races, or if it's individualized still, or what your experience was with that.
Yeah, look, I think it's very individualized. I mean, I think, as I said, there are many people. Someone came up before and talked about climbing a 14,000 feet mountain with 2 tablespoons of butter, and is a diabetic. Where are you? anyway, who was a diabetic and was fine, had no problems with blood glucose and so on. And yet there are other people who need carbs. And I think it's a very individual. I don't think we're ever going to be able to say that for an endurance athlete, they need X amount of carbs or X amount of fat. It's so individual. And as I said, there are many people who can go long distances at a fairly moderate, low to moderate intensity without the requirement of any extra carbohydrate. But it's a very individual thing. And I'm sorry, I wish I could give you a simple answer to the question, but I think it's a matter of trial and error. You've got to try in your training and see what works and what doesn't work for you, and try different amounts, different timing, and by the time you get to race day, okay, this is what works for me. And maybe you'll have a bad race, think, okay, well, back to the drawing board, and we'll try something else. But there's no one one way of doing it.
Sure. Thank you.
I'm sorry.
Thank you.
Hello, my name is Joel Sanders. I have a question on the Indiana University program for diabetics. Could you speak to the role of personal coaching, the app, and the online community in ensuring compliance and adherence to the program?
Well, so two different things. So Indiana University Health, we have a medically supervised weight loss program that operates in the freestanding clinic there at IU, and all the instruction and all is given by the providers in a group setting. Then what you're talking about through the app is Virta Health, okay. And that's different. So that's an online clinic where we're focused on telemedicine. So two different things. So so I think your question was more related to the Virta clinic, right?
Yes.
So what is specifically the question?
Just the relative importance of the app, that online community, that motivation, sharing ideas, oh, this is working for me, or recipes. What goes on? And
all of those things are important. So I think that really, the way that we think about it is truly enveloping someone in support. So it's the idea that you have a physician who's watching everything that's going on, managing your medicines. It's the health coach, which, the importance of the health coach, and there are two Virta health coaches here in the audience tonight. They cannot be understated, the importance of the health coaches. Yeah, where are they? There they are, yay.
I'll come talk to you guys.
So that can't be, the health coach-patient relationship is critical. But again, it's nice to hear from people who are experiencing the same things as you. That online community, and people being able to track their biomarkers over time and being able to get that feedback from the health coach, not just on hey, what do you want to bring to the dinner party on Friday, but hey, what happened to the ketone that dropped to 0.3 last night? You went out to a new restaurant, okay, let's go back and think about where there might have been hidden carbs, right? So and then there's resources with recipes and, more granular details. And I think that it's not one thing, right? It's all of these things. So the idea there is the right nutrition science and the right technology to be able to bring that and essentially put a clinic in people's pockets. And that way the support is there available to them when they need it, and when they want it, and when they have time to do it.
Cool. Thank you.
Thank you.
This question's for Dr. Hallberg. I'm Tanya Williams. I'm a family physician from Dodge City, Kansas, and aspiring Western Kansas diet doctor. I kind of just have a real-world question. I know we've heard about LDL doesn't matter and lots of stuff about cholesterol and HDL and triglycerides, but in your clinic, when somebody comes in and they're on a low-carb, high-fat diet and they're meeting their goals and their HDL's high and their triglycerides are low but their LDL's really high, what do you actually do about that? Do you ignore it?
No. This is an unanswered area. We have so much unanswered questions about cholesterol and how we best manage it. And so definitely the rule that I live by when it comes to this is it's a patient and physician together decision, right? So it's a shared decision-making process. And we want to gather as much information as possible. So, for example, someone comes in, they reverse their diabetes, their triglycerides are great, their triglyceride HDL ratio is fantastic. I never make a clinical decision based on LDL-C. I make it on LDL-P or ApoB. But let's just say that those things are off the charts too, right? Their LDLP has gone, crazy, it's sky high. What do? Probably the first thing I'll do is, depending on their age, especially if they're older, I'll say, next step is a coronary calcium score, right? Let's find out, do you already have disease? There are other instances where I may check an Lp(a), depending on what the family history is too, so that we can sit down together and make a shared decision. Now, I take the side effects, like David talked fantastically about, very seriously. So I don't, if someone is high risk, automatically say 80 a Lipitor, right? I might have a discussion about them and say, look, there's dose dependent, it appears, on the diabetes risk, and the last thing I want to do is give you your diabetes back. So let's talk about maybe 10 milligrams. So I may go that direction with them. And it depends on the level, it depends on their level of comfort, but it's never a black and white. It's a shared decision where we oftentimes obtain more information than just a cholesterol number that we're reacting to.
And what about pushback? Do you get pushback from insurance companies or your ACO or your Medicare, that you're not following the guidelines?
Well, listen, I'm not following anything. Like that doesn't well, okay,
it just scares me.
Wait, that didn't come out right. Wait a minute. It's not me who's going to follow or not follow. My job as a clinician is to have a discussion and let the discussion, the patient get educated on what we know and what we don't know. So if a patient opts not to get treated, that's the patient's decision. Like, my job is to feel like they have had all their questions answered. So then if anyone wants to turn on me and say, that patient's not on a statin, I'll say, talk to the patient about it. I have my documentation in there. We had a discussion. We talked about the pros and cons of both sides, because right now I feel like that's the best I can do, is have a full pro and con discussion, because it's very gray. And I'll tell you, people react differently. One of the big things is we'll have someone who comes in and their LDLP is, 2,800, they're 58, their diabetes is gone and their coronary calcium score is 0. They don't want to go on a statin, right? What would most people say? You're going on a statin. Yeah. And I say, you don't want to go on a statin? All right, I'll see you next year, bye. Yeah. And that's okay.
So you need to get as much information as you can. Listening to Dr. Diamond's talk, LDL is really pretty meaningless. Doesn't matter what the guidelines say, doesn't matter what Medicare says. That's the scientific truth. So now I've been doing this a little longer. I'll inform the patient, and if I kind of go like this, let's see, the most important thing is blood pressure and age, and whether they're not treated for blood pressure and have diabetes. If they have none of those, I'll actually go to a guideline algorithm online. It's called CV Risk Calculator. And knowing that these are the most important factors, I'll put that in, and I kind of know ahead of time, like the judges know the answer, that I know it's going to be low and they won't qualify for a statin, and I'll write it out for them and say, go take this to your doctor. You don't qualify even with this pretty conservative guideline. Of course, that then will leave a few who are triglyceride HDLs are better, and you just have to explain this is more important. This is called metabolic syndrome. You give Jeff Volek's name, have them look up all of the studies that Jeff has published, and I think you make those decisions yourself.
Okay, thank you.
So the most corrosive component in the blood is sugar. Sugar gloms onto molecules. It directly attaches to proteins. It damages the body in every possible way. And so if one's blood sugar is low, then potentially you're not looking at damaged molecules, including LDL. So if the blood sugar is very high, you're actually looking at damaged LDL, as well as, you name it, hemoglobin. The trial has never been done to compare statins to low-carb diet, for the obvious reason that the low-carb would blow the statins away. So I'm not a physician, I don't give advice, but to me, if someone comes in who is on a low-carb diet, they've got their blood sugar down, their A1C is down, what's going to happen to LDL is irrelevant, whether you're talking about LDLP or LDLC, because the LDLP is not being damaged by the sugar. And I think that is what I would emphasize to someone, to take into account the corrosive aspect of the sugar, and how if you've got your blood sugar low, you don't need to worry about anything else.
Thank you.
Similar question from the first one. Basically, like what Dr. Westman was saying, there is the ASCVD, risk calculator, in an app. And the number, the cutoff is 7.5% risk, 10-year risk of CVD. They say that when you hit that number, you start a statin for primary prevention. So what's happening now, I work in a big HMO group in Las Vegas. What's happening is we are basically carpet bombing them with statins. We were also advised, as part of the Medicare regulations, because we are a pay for results, that all diabetics, no matter how controlled or uncontrolled it is, should be on statin. And then every quarter, we get a report card on how each provider does. Let's say, oh, Dr. Tickman, only 80% of your diabetics are on statin. Bad doctor.
And those things are posted online for patients to see as well.
Yes, that's true. It's in the CMS. They also grade us on not only on the diabetics, but of course hemoglobin A1C control, blood pressure control, and my major thing is the statin. And the 7.5%, where did they get that number? From some pooled study. I actually questioned one of our cardiologists who gave a lecture for starting statins, and I told him that the number needed to treat for statins is about 84, and the PSK9 also around that number, and actually I heard crickets after that. So what do you think? What are your comments regarding this carpet bombing with statins? Our doctors are being forced into it.
Is there anyone that wants to defend statins?
No, but I have a...
Yeah, the guidelines have changed. Cholesterol is no longer critical for recommending statins. And you're absolutely right. Anyone that has type 2 diabetes now is recommended to be on a statin, regardless of their cholesterol levels. You're talking about, we're looking at over half of all adults are recommended to be on a statin. And this is big pharma, just absolutely out of control. And you've got people who are basically being paid very well by big pharma, who are seen as the leaders of this industry, and they're giving very bad advice.
As someone who is studying nutrition and strategically trying to avoid minefields that are being carpet bombed, I stay out of that, honestly, in a clinical setting. One time in 10 years of a clinical use of a low-carb diet at Duke University, I've only got one email that was upset at me, and it wasn't because the patient had a problem, or it was because I took away a statin drug. And the whole story was she was so intimidated to ask that doctor about it. She thought, oh, he's a nice guy, he'll give me permission. I took it away, and then I get this email, but it was just an email. I mean, there's no lawsuit or anything like that. I think there's a lot of unfounded fear about doing what you think is right for your patient. That I started doing 20 years ago in research, 10 years ago in clinical practice, and no one comes back to get me if the patient's better and the patient goes along with it. So I think it's a doctor-patient decision like we've been going back to for you doctor, or just stay away from that.
Thanks, Eric. I've actually got a question for Andrew. And just with your with the P.U.R.E study, you're talking about the different quintiles that we had, and there was the lowest quintile of carbohydrate intake. How applicable to a keto population was that lowest quintile? Was it anything like approaching, I'd imagine it probably wouldn't have been, it would have been well in excess of that in terms of the carbohydrate intake?
Yeah, it's a great question. So the range of carbohydrate that's covered by P.U.R.E is about 48% of energy up until close to 80% of energy. Mm-hmm. So it's highly shifted toward a high carb population. Right. Because we cover Asia and Southeast Asia and various parts of the world where there's a very high carb intake. Although we did have Canada and some European countries where there's a little bit more fat intake. So certainly, no, the range of human experience covered by P.U.R.E, and I would say most parts of the world, is not at that low level covered by carb. Now that's why I say we need more trials, like some of the work that Sarah's doing and others to test lower carb intake versus multiple biomarkers, not cherry-picked ones, but multiple comprehensive assessment. And I think we need trials, because if you do population studies of people living in communities, you're not going to cover that important range at the low end.
Yep. Thank you. Thanks.
John Madney, a family practice physician. I just wanted to mention Gerald Reven. He's an 88-year-old researcher in metabolism and diabetes at Stanford, who's going strong. At least he was a few months ago. And he's not? What happened? Oh, nobody told me.
Passed away a couple of months ago.
I'm sorry to hear that. But his work is very important, because the low carb, high fat is the key to mitigating the damage done by the pills, because there are so many pills that cause insulin resistance, and you mitigate that with the diet. So it even makes the meds safer, even though I'm not pro-med.
Okay. That wasn't a question, that was a comment. Thank you.
Hi, Miriam Burchuk, anesthesia from Calgary. Question for Dr. Hallberg. It wasn't clear to me. I'm familiar with the VERTA program and the high touch, the intensity, versus the program through Indiana University. Is it also as high touch? I guess what I'm wondering is, when you're comparing to your control group, they're just getting standard. There's no high touch, and so can we tease out how much of the success is because of the intensity of the coaching and that team that you describe, and how much of it is just the LCHF diet?
The control group was not high touch.
Right.
So, no, we cannot tease out how much was due to the high touch. And we know that part of it was due to the high touch. And that's why I think that when we look at the success of the patients, we can't say it was this aspect. It was just the nutrition advice that we were giving. It was just the health coach relationship. It was just the online support. It was all of these things. And so I think it's kind of a package deal, right? And the thing is, we were comparing it to what we normally do. Like, this is how patients are treated, the control group. So there's no question that there was a huge difference in the touch between the two groups.
So are there any studies that you know of where they've done a high touch approach but with the standard recommendations?
And we've talked about that, and that's been back and forth. The question is, redoing our entire program to be a low-fat program, and I just don't think we could stomach it.
Thank you.
Thank you.
My name is Angela Straffus, and I'm a physician in Texas, where everything is indeed bigger. And I have two questions. You talked a lot today about cholesterol, but with lipo-A, are there any studies with effects on going to the low-carb, high-fat diet and changing the lipo-A? Because certainly statins don't affect that anyway.
There is almost no evidence on that. It's something that I hope Jeff Volek has done a little bit, and he has a little bit of data on this, that it looks like it's favorable as far as dietary impacts on Lp(a). But it's something that we hope to be, we have extra blood. So it's one of the things I'm very interested in, because I think that if we could show that there was a major impact on that biomarker, that right now, we don't have anything except for niacin, so you treat your Lp(a) with niacin and get diabetes, or it's just there's not a good solution right now.
Well, most patients don't. Most physicians don't even check for that. I think that's the hidden thing. And then I have another question regarding metformin. But go
So I've had a couple anecdotes. Of course, those don't count of improvement. And Jeff had one, Jeff Volek, some years ago. But if you tell me you have blank, let's see, heart failure, you're on an LVAD, I'll treat you and monitor whatever the condition is. Any of these things, it's not like we're on the edge of a cliff, falling off with danger of an LDL of 120. So these are all measurable things that when you are using this as a therapy, even for Lp(a), you try it, you measure it.
Oh, it's definitely not going to hurt anybody. I just didn't know if there was data to back that up.
Yeah.
And then what about? Do any of you recommend using metformin to help with insulin sensitivity in the beginnings of this diet, or with diabetics, or even with non-diabetics, PCOS and so forth?
No, I don't need it.
Sometimes we keep people on metformin. And it's very patient by patient, but it's one of those medications that has an indication in prediabetes, and they've had a problem in the past. So generally speaking, we wouldn't put someone on it, but once they're on it and they've been on it, and if their A1C gets low, we have a discussion, and if they want to get off of it, heck yeah, get off of it. But it's not something that we push.
Thank you.
Let me just add one thing. I've meant to actually update my slide on platelet aggregation and fibrinolysis. LPA is clearly a risk factor for heart disease. It may very well be causal. And LPA actually interferes with fibrinolysis. High levels of LPA, you find reduced ability to break down clots. And so again, the mechanism involves clot formation and a natural ability to reduce clots. So again, blocking that clot formation. Low blood sugar means you're going to have a lower clot formation, means the LPA actually has less to interfere with to break down those clots.
Right, so it can't cause much damage if the rest of your lipid profile looks great.
Right.
Okay, thank you very much.
Thank you, everybody. I'm sorry that's the end of questions.
Oh, please,
now.
can I have just one? It's for Dr. Sarah.
Okay.
When your study is completed at the 2 years and it's published and it's in many journals and doctors have had like a year to read it, can patients hold their doctor liable for not either reading the study, taking it into account, and actually presenting low carb, high fat as a viable remedy for diabetes?
That's a loaded question. Well, I'll tell you what happened in my hospital system. So this was even before I started the study. I got a bylaw passed within our hospital organization that it was mandatory to be offered for patients with diabetes. And it got passed unanimously by our quality committee.
Beautiful. Mm-hmm. And do most hospitals?
No, I mean, I'm the only one that I know of ever that's done that. I was on the quality committee and, went and presented the data and said, I'm not saying everybody has to do this, because that's not what I'm saying, ever. But I'm saying that every patient has to know that this is a choice.
Do large HMOs have some sort of bylaw procedure, and do states also oversee HMO or bylaw procedures?
That is out of my area of expertise, so I don't know.
Thank you so
Okay,
much.
Thank you. We'll have to wrap that up. I'm really sorry about all the other questions because there'll be time for. Thank you to all the speakers and their talks.